I'm going to go ahead and open the floor for questions if I can get all the speakers to come back up here. So we had a few of you that were brave enough to try the text questions. I'm going to let the speakers get up here, but while we're working on that, there was one came in, Nat, that was specifically addressed towards your topic, and that was the question of short duct syndrome. Are you worried about leaving some of the infundibulum there as well as the long cystic duct, and should we be concerned?
So the question has to do with the cystic duct syndrome. Frankly, I don't really believe in a cystic duct syndrome. I believe that you can get symptoms following a cholecystectomy if you leave stones within either a cystic duct remnant or the neck of the gallbladder, and I've actually had to do a couple of cystic ductectomies on people who've had lap choles and stones have been remaining in the cystic duct. It acts like a little gallbladder. So yeah, if you leave the infundibulum of the gallbladder, you have to clear it out. You have to take the stones out of it before finishing the case. Then again, finding the orifice of where, as it narrows down and suturing that, but that suture nearly always is not bile tight, and so always leave a right upper quadrant drain in place.
All righty. Dr. Norbitsky. Do you still use a bougie for your paraesophageal hernia repairs? Some surgeons advocate not using one due to the risk of perforation.
Yeah, it's a good question. I actually, when I was a resident with Demetrius Litwin, we wrote a paper why it shouldn't be used, but Dr. Hennifer taught me to use it, so I've been using it for more of a, after I finished my esophageal halo closure, I'm just more careful. I think it was just an example of not good communication with the inexperienced anesthesia team, and the guy was just going too fast. I think if everything is done right and people take their time, the injuries are going to be minimal, but it's very important. I changed the way I did it, and now CRNA was not allowed to touch it, and it was a two-man job, and anesthesiologist, or one of our, somebody from the surgical team has to do it. I think it doesn't have to be used all the time, but sometimes you feel you want to just get a little bit more of a gauge how tight it is, and I use it less. I don't use it all the time, but I still sometimes do use it.
How about other members of the panel? I mean, I always use a bougie when I do fundoplications and things, but we go through a very distinct, not training, but for every case when we're going to have the anesthesiologist put down the bougie, I go through the same steps. I say, okay, when you get it into the back of the mouth, I want you to let me know. There are the little black numbers on one side. I want, as soon as it gets to about 15 centimeters, I want you to be calling out where those numbers are. If you meet resistance, stop immediately and let me know. And the other thing is to make sure your bougies have not expired, because they have expiration dates. They get stiff as they get old. And the only perforation that I've had in, I don't know, thousands of these operations was when we went back and looked at the bougie. It expired like 7 years previously, and it was hard as a rock. So be careful about that.
If you see the expiration date laparoscopically, that's bad.
We actually do use a bougie, and the nurse anesthetist puts it down probably 85% of the time. But I think the key is I tell them every single time, even if they've done it 50 times with me, if you feel any resistance whatsoever, that you need to stop. And then we take over. And it's usually me who takes over, and we put it down. I think that pulling on the esophagus, putting some traction on the esophagus, helps to keep the esophagus straight so it doesn't go against the closed diaphragm and then up and over. But our nurse anesthetist does it most of the time.
What we do is I just drop the drapes, and then I have them hand me a 60 French bougie, and then I just put my finger in the back of it. I give them a dose of paralytic, and then put my fingers in the back so I can feel the ET tube, and then slide it over the back groove of my finger until I feel it insert, and then I go back and look at the laparoscopic view until I see the tip of it come down, and then I just ease it in, and then I just change my gloves and then go back to work.
You putting bougies in, Dr. Marcello?
I use a bougie to dilate the anus. If you have a stricture, it works very well.
I'll mention from anecdotal experience to make sure if your nurse anesthetist or resident is passing the bougie, to make sure they take the nasogastric tube out. If there's one in place, we've had cervical esophageal perforations from that in the past. Dr. Jobe, there's a couple questions. Do you fashion the size of your wedge based on how much length you need? was one question. And the other question was doing the highly selective vagotomy devascularizes the cardia along with the division of the short gastric vessels, setting the stage for a staple line late. Do you believe that?
The first question, what was the first question?
Do you fashion the size of your wedge based on the line?
Yeah, basically, we just, you keep firing as much as you need. So you can go back and take several wedges if you want. There's a certain limit at which you're going to have trouble getting the fundus around to do a reasonable fundoplication, but you get what you need.
But isn't it true, Blair, though, that you, in terms of that length of that neo-esophagus, you don't want to make it too long? I mean, we try and keep it 3 centimeters or less, if at all possible.
Yeah, I mean, I think, ideally that would be good, so you don't have dilation of that neo-esophagus proximally, but, I mean, the bottom line is you need to get as much as you need in order to prevent it from, being short.
The other comment I would make is that you show pulling it all the way over. We tend to leave it in situ. We'll put that bougie down on the lesser curved side. We'll measure down how far we want to go, and I'll put a stitch there right next to the bougie, so I have a marker. And then we use one of the articulated staplers coming in from the surgeon's right hand, and because you can pull it, the fundus kind of toward the stapler, usually with that articulation, you can just leave it in that orientation, staple right to your suture, because that's right where you want it, and then go straight up. And it always amazes me how small that wedge actually is when you actually take it off.
So, and the question about devascularizing the area by doing a highly selective vagotomy and taking the short gastrics.
Yeah, I'm not worried about that, and it hasn't been an issue.
Okay, and there's another question for Dr. Norbitsky's. Said that looked like a devascularized esophagus.
Well, it wasn't. First of all, it's very hard to devascularize the esophagus, and the fact that postoperatively the patient hasn't had any complication just proves the point that even though it looks purple just from the traction and beating it down, that's not the sign of devascularization or significant devascularization. At least that's what Dr. Hannaford used to tell me.
Now, Dr. Jobe, you presented some great techniques on esophageal lengthening. You did not show Nowitzki's jump rope with the esophagus procedure. Do you see how slack that thing was? It was quite a big mobilization.
Question at the front microphone.
Lars Andersen from Denmark. When you do these difficult laparoscopies and laparotomies and find some unexpected things, do you think there's room for a second look laparoscopy, or when do you used to do that?
Second look laparoscopy. So can you give me an example?
If you have, for instance, the leakage, the bubbling problem or so, would you take a second look or something like that?
Yeah, generally I would say no. I haven't done that to begin with. So if you have a leaking anastomosis, you put 3 stitches in and do an air leak test and you think it's okay. The truth is that of that group that I showed, those 41 that were treated by suture alone, the data that I don't have to give you is what was the status of the donuts, were they looked at endoscopically or just the rigid procto for insufflation. And then maybe there's a role for looking, but I don't know what you'd be doing another air leak test 2 or 3 days post-op. There's probably going to be some adhesions that may be beneficial in that setting. I've actually can become more conservative, and based upon that data, I'm more easy to hang a loop. Especially in most of the studies say that obesity is not a risk factor for anastomotic complications, but I can just tell you in our own experience, it certainly seems so. So if somebody with a big BMI 30, 35, 40, and I do a low anastomosis and there's any concern, or even not, I'm more likely going to divert those patients than I was 10 years ago.
How about if this patient weighed 375, and you're really going to have trouble bringing a loop up, and they got just a tiny leak down there? Is there still going to?
You got to do something, and that's my feeling. So here are your options. One is you can make it an end loop. So what you're going to have to do is divide the TI, go down into the mesentery. You'll never bring that end of the bowel up, but you go back about 4 or 5 cm from that cut edge, then now you've got an end loop, and that'll reach in most every patient. Now, when it goes to reversal, that's going to be a trouble because you have to mobilize like the right colon up and pull it up later, but that's something which I worry that if the patient gets a leak, will they die from the operation?
Absolutely.
And that's the biggest trouble I get into.
What I worry about a bit is you have posed this question to one of our residents, and they've seen people who will take perforated diverticulitis, wash them out, and drain them, and that was their answer for a low anterior leak.
Dr. Marcello, how about stenting?
Yeah, so we didn't talk much about the other options for leaks, and I think there are some areas along stenting, maybe not as much, but clips. I've had several cases where I've tried to put the clips on. The hard for the same thing, sigmoid resection. The hard part is the clip isn't always as strong as you'd like to reinforce the surfaces. But what I did was I used the TEM scope. The problem is the TEM scope is a 40 millimeter scope, and your anastomosis is 29. So you can only get the TEM scope up a little bit, and then beyond that you have to put your instruments through, and actually you've repaired the anastomosis. These were in cases of a controlled leak with the drains in place, and rather than leaving the patients on TPN for months, I went back and closed this. I think we're going to see more endoluminal management of anastomotic complications. But if there's a lot of pus in the abdomen, they don't suck out so well through those little IR drains. And so we're still not going to see that. But I think we'll see more endoluminal managements of anastomotic complications, probably both above and below. How about on the top side? You guys doing any of that?
Well, I don't know if Dr. Pomsky, Dr. Marks are here, but with those guys around, they do use a lot of stenting and in very unique circumstances. So not everybody is lucky enough to have significant endoscopic support available for those kind of cases. But I think I also heard not waiting for the leak, but in cases of this kind of failed water test, put a stent kind of preemptively, and you don't think that's done routinely a lot.
The hard part is knowing, will the stent itself be enough of a barrier to the bacteria and everything else, and is there any element of ischemia when you put the additional sutures? The hard part also is going to be, it would take, it's an 8% leak rate, so we'd need a large study, randomized. Boy, that's going to be a tough one. So many other variables. Somebody's probably just going to do a series, and then maybe it would prompt us to do a study.
One of the problems with the foregut stent is the migration. When we don't have a stricture there or anything, it will cover the perforation per se, but long-term keeping that in place or even short-term to allow it to heal is sometimes difficult due to migration.
Blair, what about, so Yuri showed the perforation. So let's say that repair leaked on day 1 or 2 or whatever. What about endoscopic techniques to try and control that? Or what would you do at that point?
I think if it leaked, then I would take the patient back, drain the right chest, and give them plastic toxicity. I'd put a lot of drains in, and then wait it out, and then probably even consider diverting them proximally and put a feeding tube in distally. That's how I'd handle it.
Yeah, the patient I put a tag, just higher chance of that happening, but didn't happen luckily. Interestingly, we had a case before I got to a case of very distant distal esophageal perforation, 2.5 weeks post paraesophageal hernia repair. Patient presented with abscess, turned out to have a kind of persistent hole there, and I know they stented it, and resulted in complete healing without any operative intervention. So it could be done, but I guess you have to have experienced people doing it.
There are several questions that came in over the text that have to do with specific questions, particularly with meshes and the coating barriers, as well as the hemostatic agents and being on the conflict of interest task force. I'm going to ask you if you have those questions come up in the speakers specifically so we don't mention product names from the podium. But I want to acknowledge that we did get those. Dr. Soper, there's a question about the role of laparoscopic ultrasound with a difficult gallbladder. You've got some opinions on this?
Yeah, we actually, a number of us, led by Junji Machi in Hawaii, wrote a paper that I think was published about a year and a half ago now, talking about the utility of intraoperative ultrasound to avoid bile duct injuries. Now, that's, it was a retrospective study. It's hard to really know. But what I can tell you is I use ultrasound routinely to look at the bile duct during lap choles, primarily to teach our residents how to use laparoscopic ultrasound. But it's much faster and more sensitive for common duct stones. But for some of these really difficult gallbladders, when you get in there, it looks like a bomb has gone out. You can't really tell where the gallbladder ends and the bile duct begins. often early on we'll bring in the ultrasound probe, find where the common bile duct is. You know, we'll have a clip or some marker where you think is the neck of the gallbladder, and you can then tell how far away you are from the common bile duct, and gives you a really good sense as to whether you can dissect in the area that you think you can dissect in. So, and I think the incidence was something like 2 or 3%, where that early ultrasound did help with the dissection on particularly difficult cases.
There was a question that was directed to Blair, but probably has some implications for the colorectal stuff. What about reinforcement strips on staple lines? Any role for those?
Sure. I'm not sure if they'll help or not, but it makes you feel better. Oftentimes what I'll do is just take a strip of Omentum and put it up there next to it, and then maybe even wrap around it. Or if there's exposed staple line when you do your fundoplication on the inferior aspect, usually it's incorporated within the fundo. But if it's not and it's exposed, then I would take a strip of Omentum and lay it on top of there. But
how about the commercially made buttresses for the staplers? You put those on, do you think that reinforces your staple line?
I haven't used them.
Okay. Did you use any of those, Peter?
No, there was some interest in doing it, and there still may be in terms of a study. It take about 1,000 patients to really show benefit for left-sided and pelvic dissection. The hard part is knowing, is that the answer? Is it just the buttress enough, or are there other factors that will still lead to leaks? And when a smaller study was started, it had to be stopped because the leak rate was so high in both groups, it would never reach significance.
And then one of the last questions was for Alfie. Any minimally invasive procedures as far as fibrin glue, plugs, etc., for enterocutaneous fistulas resulting after removal of these meshes? And I think we can probably pass that along the panel.
Not that I have personal experience with. It's one of those, you know, the enterocutaneous fistula is either a missed injury or it's a repair that leaks, but no experience with plugging it at all. I mean, there's been published reports of biologic plugs that have been used, and then fibrin glue or fibrin sealant of one variety or another that's been used, but I have no personal experience with its use. That's something that needs to be treated in the traditional fashion of bowel rest, waiting, and if it doesn't heal, then a reoperation.
Peter?
Yeah, in my experience, we get a lot of this sometimes when a patient's had an anastomosis from another service, and we get consulted in. A success rate with fibrin glue is about 1 in 4, but it's a highly selected group. You need a sinogram, and you need to make sure it's just truly a tract without a central pocket to have effect. And it works best if you can actually visualize the bead on the inside. And for me, it's 1 in 4. That's as good as it gets, because most of them are still 3/4 are going to need an operation. Don't burn any bridges, but don't tell the patient to hope too much.
Any other questions from the floor? Again, if you've got specific questions about products, please come up and ask them. I don't want to put the podium up here advertising any particular products. Otherwise, I appreciate you participating. Please fill out any evaluation forms.